Thank you so much. So thank you again. And you asked me to speak about the EHA and ESMO guidelines, in fact, and what has changed recently. When we are looking at the guidelines that were published 5 years ago, you see that for young patients eligible for autologous stem cell transplantation, we were proposing at that time only triplet induction. And you see that there was a list of VD-based combo plus thalidomide, cyclophosphamide, lenalidomide, and PAD, in fact. And now we are only proposing in the new guidelines VRD, and we are also proposing as a first option a quadruplet combination that is VTD plus daratumumab. So VRD and stem cell transplantation is very well established, as you know, very popular. And we have 2 trials showing that VRD and stem cell transplantation is highly effective. One from France with a 1-year maintenance with LEN, and the other one recently published in the New England from US with LEN until progression. And the results are very similar, showing that stem cell transplantation is the best option upfront for PFS versus VRD alone. And you see the huge impact of the duration of maintenance. In the US trial, LEN was proposed until progression. In fact, the median duration was 41 months, 3 years and a half in the paper. But you see that the median PFS increased from 47 months in the French study up to 67. So definitely very good results. But why not using a quadruplet combo? And you showed already the study design of the Cassiope trial with more than 1,000 patients enrolled, comparing VTD versus VTD plus daratumumab. And before maintenance, the MRD negativity rate, 10 to the minus 5, intent to treat, is highly improved with daratumumab, 64% versus 44%. And this depth of response translated into a better progression-free survival and also a better overall survival. So now in Europe, VTD DARA is approved and is widely used, in fact. But should we use VRD or VTD DARA? Obviously, we will never have this head-to-head comparison, and we have indirect comparison showing that not only PFS is improved, but also overall survival. This is a match-adjusted indirect comparison of VTD DARA versus VRD. And I think that if we can use, if it reimbursed in your country in Europe, VTD DARA, to my opinion, is better than VRD in terms of response, PFS, potentially overall survival as well. We have to wait for VRD DARA, as you know, phase 3 data are not yet available. Regarding the conditioning regimen in the new guidelines, MEL200 is the standard of care, in fact. And I would say disappointingly, we had the results of MEL200 versus BUMEL during the last workshop in Los Angeles 2 months ago. And the Spanish group did compare prospectively BUMEL versus MEL200, and there is no difference regarding PFS and OS. So MEL200 is here to stay for sure. But why not using a tandem stem cell transplantation? So in the guidelines, we are proposing tandem stem cell transplantation in patients with high-risk disease. We had an old meta-analysis from Dr. Cavo, but Michele also reported the EMN02 study. And when you are comparing single versus tandem in the EMN02, there is a PFS benefit, but also an overall survival benefit. And this is especially true for patients with high-risk disease. And this is a sub-analysis of EMN02 single versus tandem for 17p deletions. So into the guidelines, we are proposing tandem for patients with high-risk disease. And maintenance, LEN until progression. So no change, in fact, since 2017. And we know this meta-analysis, 1,200 patients, overall survival benefit of LEN in blue versus no LEN or placebo. But the future potentially will be LEN plus daratumumab. And we have this Auriga study ongoing. After stem cell transplantation, patients are randomized 1:1 to LEN or LEN plus DARA sub-Q. And there is also another important study ongoing the German HD7 study looking after stem cell transplantation of len versus len plus isatuximab. But these proposals are not yet implemented in our guidelines. So for elderly patients, in the past, we were proposing VMP, Lendex, or VRD as first option 5 years ago. And now definitely we are not proposing VMP frontline or Lendex frontline. VRD is remaining proposed in the new guidelines, but we have also VMP plus daratumumab that is proposed, or DRD, Lendex daratumumab. So the SWOG study did establish VRD followed by Lendex as one of the standard of care. You know that the study was updated, in fact, 2 years ago. The PFS is quite good, in fact, even for very old patients, 34 months. But you know that this study did include not only elderly patients, but also younger patients. And when we are focusing for overall survival on patients older than 65 years of age, there is no significant difference when looking at VRD versus Lendex. VMP-DARA is also one of the standard of care in the new guidelines based on the Alcione study published by Marivi in the New England and updated as well 2 years later. There is a PFS, a strong PFS benefit, median 36 months. That's roughly identical to that of VRD, in fact, but also importantly, an overall survival benefit for DARA VMP. But to my opinion, the best regimen that is proposed into the new algorithm, new guidelines from EHA and ESMO is DRD based on the Maya study. This is a true study focusing on elderly patients. The median age was 73 years, in fact, in the study, and 14% of the patients had high-risk disease. We have also more than 40% of the patients that were older than 75 years. And definitely a strong PFS benefit. The median PFS is 62 months. So that's really outstanding for a very elderly patient population. This regimen is becoming now the standard of care, the most popular when this combo is available and reimbursed in different countries in Europe. But look as well at the overall survival. There is a strong benefit for DRD, and the median OS will be potentially more than 8 years for very old patients. So many of them are not going to die from myeloma, and that's, to my opinion, a very important step forward. So what about relapse patients? You know that in the past, we are considering first relapse after IMiD, first relapse after bortezomib. And now we have changed, in fact, the guidelines, and we need, at the time of the first relapse, to look at the refractoriness, yes or no, to lenalidomide. Since we are using len maintenance, we are using VRD followed by len continuously. So many patients are progressing on lenalidomide, len refractory, and the three best options into our guidelines are either POMVD, KD-DARA, or KD-isatuximab. POMVD, based on the Optimism study, this is the subgroup analysis of first relapse len refractory patients, and you see the benefit is important in favor of the triplet with a median PFS of 18 months. The second option is KD plus daratumumab. This is the update analysis of the CANDOR trial showing a huge PFS benefit with KD-DARA, and this is also true for patients len refractory with a hazard ratio that is less than 0.5, in fact. And recently we have updated the IKEMA trial looking at KD plus isatuximab, and you see that the median PFS is the best one ever achieved, in fact, with a PI-based backbone, 36 months, 3 years of PFS. And this is also true for the subgroup of patients len refractory, but those patients were representing only 30% of the patient population. So KD-DARA, KD-isatuximab, or POMVD for len refractory patients. And when patients are not refractory to len, either len naive or len sensitive, DRD based on Pollux is definitely the best option. And we can use a different combo, in fact, Lendex plus Carfil, Elo, Ixazomib. I will not discuss those trials because I believe that Lendex daratumumab for Len-naive or Len-sensitive patients is the best option. This is the update analysis of Pollux in patients with one prior line of treatment, and on the right-hand side, prior lenalidomide exposure, Len-sensitive patients. And you see definitely that the median PFS is very good, above 3 years with DRD. At second subsequent relapse, we were proposing into the guidelines in 2017, Pomdex as a backbone or daratumumab single agent. In fact, we have to forget Dara single agent since we are using Dara upfront now at the time of the first relapse or even frontline. And Pomdex is totally, to my opinion, a suboptimal regimen. Pomdex was compared with Pomdex plus a CD38 antibody, either Dara or isatuximab, into Icaria and Apollo. Obviously, we can use KD as a backbone as well when Carfil was not used at the time of the first relapse. So let's focus on Pomdex combo. And this is the Icaria data, Pomdex plus isatuximab. All patients were treated at the time of the second relapse into this study. So that's a study focused on Len previously exposed or Len refractory patients. So Pomdex isatuximab, you see the huge impact of the addition of this monoclonal antibody that is now proposed into the guidelines. This is also true for Pomdex daratumumab based on Apollo, although we have 10% of the patients, roughly 10-15%, that were treated at the time of the first relapse, but the great majority of the patients were treated at the time of the second relapse. So PD daratumumab is also one good option, and you see the hazard ratio of 0.63 in favor of the triplet. We can also use, available in some countries, not all of them, Pomdex elotuzumab, based on the update analysis of the Eloquent study. The PFS is in favor of the triplet, but that's only a phase 2 trial, and I'm not sure that Elo is very effective when patients were previously exposed to CD38 antibody. So when patients are now progressing, becoming triple class refractory, the guidelines in 2021 are recommending either selinexor or belantamab mafodotin, and you discussed previously about selinexor, to my opinion, a suboptimal regimen with a PFS roughly of 3 months, an overall survival of 8 months in triple or penta-refractory patients, and we know the toxicity of selinexor with this schedule, with GI toxicity, fatigue, and the belantamab mafodotin data were updated by Sagar-Lonial, and you see that the median PFS is also suboptimal, to my opinion, with an overall survival of 1 year, with this issue of the ocular toxicity. So definitely the future is immunotherapy, and that was not proposed in the guidelines because the landscape is changing very, very quickly. In fact, ide-cel was approved in 2021, and ide-cel is the first CAR-T available. You discuss this data, 82% of response in very advanced patients. That's really amazing. The PFS is 1 year at the optimal dose. The overall survival is 2 years at the optimal dose. So definitely a big plus. But in Europe, we have very, very few slots, and the access is a big issue. Cilta-cel was recently approved as well, and not available at all, in fact, in Europe yet. We are just about to start in France the first compassionate use program, but those results are really amazing with a 98% of response, including 80% of stringent CR. And you know that Tom Martin updated the analysis of CARTITUDE-1, and you see that the 2-year overall survival of 74%. But this CAR-T is not yet proposed into the new guidelines, but we have to update the guidelines continuously, including now bispecific antibody. And you discuss that teclistamab was very recently approved in Europe, and this week in the US, Europe did approve Tecli first before the US. That was for us very encouraging, I would say. And you know that the median PFS with these bispecific antibodies is 11 months. So definitely in the near future, the future guidelines, we are going to add CAR T-cell therapy and bispecific antibodies for triple-class refractory patients. And I thank you for your very kind attention.